Well, thanks for joining me back again in another lecture of toxicology. Today I'm talking about drowning. This will be the last lecture for the series of toxicology lectures delivered via Google Classroom to Year 5 medical students. Introduction. Non-fatal drowning is defined as survival, at least temporarily, after suffocation by submersion in a liquid medium. Many authors include loss of consciousness as a mandatory finding, while submerged as a criterion for the syndrome of drowning. However, pulmonary complications might follow aspiration of water even without loss of consciousness, though non-fatal drowning should be defined in a different way or reformulated in its definition to say that it's survival at least temporarily after aspiration of fluid into the lungs. That's a frank aspiration, and this would be called wet non-fatal drowning, or after a period of asphyxia secondary to laryngospasm, and this one would be called dry non-fatal drowning. Epidemiology. Drowning is a common cause of accidental death and an important cause of childhood fatalities all over the world. It's been estimated that annually more than 370,000 people die from drowning. In addition to this number, there are many people who die from drowning. In fact, they are unestimated because simply they might come with certain situations like natural catastrophes of tsunamis, casualties of some religious behaviors like those in Ganges River of India. Certain people might suffer from drowning during recreational ceremonies, and this one would be common among our people, those who are going for camping outside the cities, and they every now and then we hear about young people suffer drowning during these incidents. And in addition to that, the recent era of immigration, and importantly the one that happens across the Mediterranean to Europe. And you know that yearly thousands of people are trying to immigrate, but in an illegal way, unfortunately, and this would be going under certain unusual environment and without backup facilities. Many of them die during their immigration. Now, it's just an estimate of WHO. Just in January 2019, more than 200 people died because of drowning into the Mediterranean Sea. Basically, low and middle class countries or income countries would have the highest rate of drowning, and the highest incidence occurs in males, especially Afro-Americans and those with low socioeconomic status. Drowning generally is more common during summer months, and the age distribution generally is bimodal. The first peak would happen in those under 5 years of age, and this basically because of lack of supervision when they being around swimming pools or being in bathtubs, and happens even in a bucket of water they might die. It's very easy for small kids to die, especially non-supervised. And the second peak happens in the age group between 15 and 25, and those people more or less would have drowning because of risk-taking behavior. Risk-taking behavior is very dramatic event in teenagers, and youth people might go and try some abnormal, or let's say that some dangerous, risky behaviors while swimming in rivers and in lakes and beaches. And pathophysiology. Fatal and non-fatal drowning typically begins with a period of panic, from the threat of that drowning would be in the mind of the victim in every moment. So there would be loss of normal breathing pattern, and the patient tries to hold his breath, but in fact this would be pointless, because in the end he would try to struggle and compensate, and in the opposite or in the reverse you would find the patient have air hunger instead. And this inspiratory effort would be evident in the end and leading to hypoxemia, whether the patient is breathing or not. This is something inadvertent. The body cannot compensate without oxygen, cannot abandon the breathing cycles for more than few minutes. So by means of the aspiration of fluid, even in a small volume, like in a 50 kg man, like having 150 mils of water, when it's in a gush into the airway, it would induce a severe laryngospasm. And this is the contrary to the common belief that the water is going to fill the lungs. This is not true. In fact, small volumes of, let's say, 3 to 4 mils per kg is enough to induce severe laryngospasm, and this secondarily would cause some dramatic hypoxemia. And this hypoxemia, it is known that it affects target organs, mainly the cerebral function. So the cerebral ischemia is the main end or final result from hypoxemia, as you know, in spite of good and circulating blood that traverses the lungs, but in fact the lungs are not able to deliver oxygen into that blood. The distinction between salt and freshwater drowning is no longer considered important. I mean, it's clinically not important, but in fact this is more or less important for the field of forensic medicine, to know whether the patient had been suffering this incident in salt water or in fresh water, because both of them would result in decreased lung compliance. I mean, they make the same pathophysiologic processes, they cause ventilation perfusion mismatch, and the shunt intrapulmonary that happens because many of the alveoli are not going to participate in the gaseous exchange. That's why the microvasculature of the lung and the macrovasculature is trying to do shunt of the blood immediately from the right side to the left side without gaseous exchange. This would lead to dramatic hypoxia that causes diffuse organ dysfunction. The end organs that are affected in drowning process, mainly pulmonary. As we mentioned that both salt and fresh water would have a similar pathophysiology. The main mechanism is the washout of surfactant. I know that you probably heard about surfactant. That's the compound that's lining the small airways to keep them open by changing the tension, surface tension. So washing out the surfactant will produce non-cardiogenic pulmonary edema. It's not because of the heart is failing, but this one is because of the lung is dysfunctioned in its own. So there would be acute respiratory distress. Pulmonary insufficiency can develop insidiously or rapidly, and signs and symptoms more or less are simple, like shortness of breath, crackles and wheezes. Not more than that, in fact. Chest radiographs would show pulmonary edema, whether these patches are localized or perihilar or could be diffuse, involving the lungs diffusely. I mean, it affects both lungs. And the formation of froth. This is the important mechanism in the cycle or the chain of pathophysiology in drowning. Whenever there's water or liquid inside the airways and there's an effort for from the person to breathe, there would be introduction of air plus liquid into the airway. This mixture would be very quick because the airways are narrow and the air is going to flow quickly, making froth. The froth is a mixture of many compounds. In addition, you know, the natural things that happen in the lung, like the mucus, plus other compounds that are coming from outside, namely water and air. And so in the end it makes a froth. And this is very dramatic, although it's a very nasty picture to see somebody having froth coming out of his mouth when they pulled out from the river, for example. Froth is a very dramatic finding. It comes out from the nose and the mouth, and it dramatically blocks the airway and prevents further air to go inside to the target parts, I mean the parenchyma of the lung, the alveoli, to do the gaseous exchange. So that froth is unfortunately the nasty picture of drowning. The other organ is the neurologic organs, namely the brain. As I told you, the hypoxemia and ischemia, both of them cause neuronal damage. It causes cerebral edema here, and cerebral edema elevates the intracranial pressure. Not uncommonly, patients might suffer from coning, cerebral coning or herniation. They go down with the tentorium, and impingement of the brainstem would further increase the culprit on the respiratory system and affect the vital centers there. This kind of trauma might be also associated with another thing. Don't forget that with drowning there might be some secondary injuries like neck injuries. While patients are diving down, they have their heads hitting some objects like rocks in the bottom of the river, or they being pushed by the big waves of the water and being struck against the foreign objects. So there might be some other associated events happening and causing neurologic damage. So not uncommonly we see patient having intracranial hemorrhage or having a cervical injury in addition to the event of drowning. Some non-fatal drowning victims might sustain neurologic damage which might continue for longer period despite successful cardiopulmonary resuscitation. So this would take a longer time for the recovery, and sometimes the recovery would be not complete in fact. Cardiovascular events here, arrhythmia, are very common, especially when there is hypothermia in addition to the hypoxemia that's expected in drowning. So here in non-fatal drowning victims, you might initially expect asystole and tachycardia, sometimes bradycardia, and even you might see atrial fibrillation. So in those individuals you might find pulses are thready or even pulseless. Don't forget, please consider this in the clinical exam that we are going to discuss in the coming few slides. There is a new piece of information here. They found that people who have some congenital long QT interval syndrome, there are many varieties of them. Just mention type 1. I'm not going to go into the details of this and what is that, but in fact they found that many people, when they sustain the drowning event, they have another factor eventually ended in drowning, and primarily they have some arrhythmia once their body is under the water. With diving or swimming, touching the body with the water induces kind of arrhythmia, ventricular arrhythmia, because they have congenital long QT syndrome, and this was not known to the patient at all. So they didn't notice that abnormality that they had for a long time, even though they might be some professional swimmers, but they die because of the ventricular arrhythmia that ends up in a drowning that's unexpected. So he is a swimmer, but once he had some arrhythmia, he can't swim, he can't maintain himself with the normal perfection of swimming because of the arrhythmia that he had. So the end result would be drowning. So this would be put in consideration, especially in the last few years. They put a spot on this syndrome as one of the reasons behind drowning. Changes in the electrocardiogram of small number of patients might show myocardial ischemia. Whether this ischemia happened before the event of drowning, or I mean it was the cause of drowning, or probably it comes after that because as a complication of drowning. Nevertheless, both of them is showing the same thing in the ECG, so they should, in management, you have to put a consideration and point to myocardial ischemia as well. Acid-base balance. There would be a respiratory or metabolic acidosis. Electrolyte imbalance is not that major drama here, because the dilutional effect of fresh water or the concentrating effect of salt water, both of them on the lung and through the diffusion membrane to the blood, is rather uncommon. The reason is that because it needs large volume of fluid. Like, it's not 3 to 4 mils per kg. In fact, this needs more than 10 or 11 mils and up to 22 mils per kg of water to go and fill the lungs to make changes like dilution of the plasma or concentrating the plasma. This is rather uncommon. Don't expect fresh and salt water to change much in the plasma, except in certain exceptional conditions like diving or drowning in a highly concentrated liquid medium like in the Dead Sea. Certain people might suffer from hypermagnesemia or hypernatremia or hypercalcemia even due to absorption of the water. It's a swallowed one, it's not the inhaled one. It's basically going through the stomach rather than the lung. Now, renal complications also would be expected because of, it might be hypoxemia that affects this vital organ. Shock is another factor. Hemoglobinuria, whether there is some myoglobin or hemoglobinuria or cold diuresis, all of these 4 factors might end with acute tubular necrosis. Hemolysis and coagulopathy, both of them, and the coagulation defects might be expected, although they are rare, but there could be potential complications of non-fatal drowning. Management includes 3 lines: pre-hospital care, emergency department, and inpatient care. Pre-hospital care and acute interventions. I included 5 spots here. Ventilation is the most important one, in contrast to the other kind of incidents that I mentioned in the previous lectures, like giving antidote or giving high flow oxygen or whatsoever. Here the priority is going for ventilation. Do ventilation as you're going to push air, the exhaled air that comes out from the mouth of the resuscitator goes into the lung of the victim, and this would be pushed under the pressure of exhalation. By the way, this is the best thing and the first thing to be done, because it should be done first, because once you had a good place for resuscitation to start, like a shallow water or even on a hard place like on the ground, you start to give a couple of rescue breathing, enough to be expanding the chest of the victim to have some chest elevation in front of your eyes. If you try to use something to give a bit of separation between your mouth and the victim, that's not a problem, but it's not all the time available. Having a face mask or pocket mask, these things are not available, unfortunately, in most of the incidents. Now, drowning patients would have, as I mentioned, would have some life-threatening arrhythmias, and pulse is not all the time detectable. Some patients have weak pulse, some patients are pulseless, especially when there is hypothermia, and having few arrhythmias like bradycardia or atrial fibrillation. So the best effort is to go and detect these pulses, because they're very important to find them and changes the decision of the mode of the resuscitation. And try your best to check it for at least 1 minute. Give it a time and let it be done. If the patient was not responding to a couple of rescue breathing, and you found that patient is pulseless, so you immediately start with compressions of the chest in the manner that you know in life support, in the CPR techniques that you've been trained on. Certain behaviors like Heimlich maneuver is useless. Putting the patient on one side and thumbing on the back, all of these things are useless, are of no proven value. Please don't try them at all, and try not to waste time, because time is very detrimental, a big detrimental factor in the early few minutes of resuscitation, and this will be shown in the coming few slides as well. High flow oxygen to be given to the patient if it is available. This is a good point, but only to be given to those who are spontaneously breathing. Otherwise, it's pointless for you to give rescue breathing and push the oxygen. Can't be pushed inside unless you have some ambo bag and you connect the oxygen tubing with it. Otherwise, it's useless. Any apneic patient should be intubated immediately if the facility available with the paramedics or those people who are doing the rescue, they were good and had good training on doing that. It's fine to put intubation for any apneic patients. because apneic patient would have high mortality, and the target is to go and do the resuscitation as soon as possible, because every minute counts. Attempts in rewarming hypothermic patients should start from the first moment and should continue with the patient while being taken to the hospital. Emergency department management. Here in the emergency department, the asymptomatic patient who have indications for intubation should be intubated immediately, and the following would be the indications. Any signs of neurologic deterioration or inability to protect the airways, because the airways are important here. Even the patient being outside the scene of drowning, I mean, he is outside the water, but don't forget that a lot of water is collected inside the stomach and being swallowed. So the patient with some depressed consciousness can't protect his airways, and he might have another attack of a gush of water going into the lung, because the water is being stored inside the stomach, which is dilated really. The second indication is inability to maintain partial oxygen more than 60 or oxygen saturation more than 90, despite giving high flow oxygen. This is another indication to intubate the patient and have some respiratory support. Any carbon dioxide partial pressure more than 50 is another indication to do intubation. Once you had intubation or the trachea being done, then you have to think about evacuating the stomach from the fluid that's swallowed. Here, a nasal or oral gastric tube should be placed into the stomach and trying to aspirate the collection of the fluid, and this would be very important, because any gastric dilatation because of fluid would impair the oxygen transport mechanisms of the lung, and the lung function would be impaired because basically it compresses the diaphragm. But the second thing is that it carries the risk of aspiration of that fluid. So the gastric decompression is mandatory once you had tracheal intubation only. Without that, you are not probably allowed to do the nasogastric intubation. The second thing is for symptomatic patients. Whenever you have somebody who has symptoms that don't require intubation, I mean they don't have the indication above mentioned, you give simply oxygen to keep his partial oxygen above 94. Any wet clothes should be removed, and rewarming as a continuation of the process should be continued here for any hypothermic patient. Asymptomatic patient who have nothing to be dealt with should be closely observed in the casualty department for up to 8 hours, according to the standard of the country. I mean, you probably have some watching the patient for a while for the 8 hours. If vital signs and pulse oximeters and things like X-ray are all normal, the patient could be discharged by the end of the observation period and let him go home. The inpatient management here, certain patients who are symptomatic should be admitted to the hospital for supportive care, and especially for the patient who had some organ specific damage or complications. Neurologic injuries would be dealt with in this section. Major determinant of neurologic outcome are the duration of the loss of consciousness and the neurologic state upon which the patient presented with. So the worst thing comes with those who have low Glasgow Coma Scale and the longer duration of that status of loss of consciousness. Treatment modalities include elevation of the head of the bed, the head of the bed, not the head of the patient by himself by a pillow. The whole bed should be elevated to up to 30 degrees, and this would be preceded by an important step, that is exclusion of cervical spine injury that I mentioned in the beginning of this lecture. Otherwise, with the spinal cord or cervical spine injuries, you know that it's contraindication to do a lot of mobilization of the neck. So you probably make another jeopardy and further deterioration of patients' consciousness and mental status. Diuretics can be tried if there is hypovolemia. For patients with imminent danger of cerebral herniation, hyperventilation might be done, and this would be achieved by mechanical ventilation. You put the patient on hyperventilation, and this would constrict the cerebral blood vessels and reduces the pressure inside the brain to prevent cerebral herniation. Seizure, as you know, increases cerebral oxygen consumption and blood flow, and this would be detrimental, has negative effect on the intracranial pressure. So this should be best treated with a non-sedative or non-sedating anticonvulsant. Phenytoin would be a good choice, because if you gave a sedating anticonvulsant, probably it would mask the Glasgow Coma Scale, and it overestimates the loss of consciousness. In the subsequent steps of follow-up, it would be affecting your decision negatively. Respiratory failure. Now, respiratory failure or infection, here bronchospasm is a major factor to be treated, and it's treated just like bronchial asthma. I mean, you give the patient bronchodilators, but don't forget that there is no the cascade of inflammatory reactions and the inflammatory mediators of asthma, so there is no need for corticosteroids to be used. Antibiotics could be used only if there was some frank evidence of pulmonary infection, or the patient at least being submerged in a very dirty water like the sewage system. If pneumonia is there, you have to think about some waterborne pathogens like Aeromonas, Pseudomonas, Proteus, and these are main pathogens in dirty water to cause relatively severe pneumonia. The outcome. The following factors at presentation should be addressed in the beginning to expect the prognosis. And I'm going to show you a very beautiful table in the end of this lecture. But let's go through the points that affect prognosis. First, duration of submersion, which was more than 5 minutes. Time to effective basic life support was spent more than 10 minutes to reach the hands of the resuscitators. Resuscitation duration, which continued more than 25 minutes without good effects. If age was more than 14 years. If Glasgow Coma Scale was less than 5. If there was persistent apnea and requirement of cardiopulmonary resuscitation in the emergency department, or if there was some arterial blood pH less than 7.1. And the grades would be with the mortality expected in each one of those cases. If there was only cough, no foam, mortality is almost 0. While in the yellow zone, if there was some small foam or large foam coming out of the mouth or the nose, the mortality would range between 0.6 to 5.2. Still, there is oxygen therapy and hospital treatment, but in the red zone, there would be large foam. There would be in stage 5 another event that is respiratory arrest, and in grade 6 there would be a cardiac compromise and arrest. So in these situations, the mortality would escalate from 19 to 44 or even to 93. The treatment modalities here are not just admission with hospital monitoring, but in fact there would be other modalities like IV lines, like positive pressure ventilation. PPV stands for positive pressure ventilation, and even the cardiac arrested patient would have CPR and trying to revert the whole pathologies, but unfortunately it's a gloomy one and mortality rate is relatively high, so you might expect up to 93% mortality if any patient presented with cardiac arrest. This is the unfortunate patient. Probably he is unfortunate more than those who had respiratory arrest. Probably this is the end of our lectures, and hoping the best for the next.